So, good morning again, and we are approaching probably one more lecture and one more session for review. It could be the way I'm looking for it is that we will discuss half of that session, we discuss new material, and then probably another half is to go through a review, so that you get familiarized with the questions and how the final exam looks like, and how do you study the material, because the material is getting more complex, as we mentioned many times. So I just hope that you guys are really going through the material. Statistics wise, I'm sorry to tell you, it doesn't show that you guys, all of you, are going through the material, because I could see how many hours you spent on Brightspace and watching the videos. So for those who are not really doing the reviews, is going to be accumulated on you, and that's going to be not fun in December. Today's lecture is about cardiac diseases. I just wanted to narrow that down to only heart failure, because cardiac diseases, we need probably one whole semester to discuss it. So we are condensing it so much to fit within 2 hours. I have somebody to ask a question. Will today content? No, today's content are not included in the quiz. Today's content is not included in the quiz. Okay. So as usual, please come to office hours whenever you need, and take advantage of discussing the issues that you are facing and revisiting the material. So in general, today we will go through the cardiovascular system. We will look at the anatomy of the heart, and we're going to look at the anatomy of the heart just to point out the central causes of the disease. We are not going to go study the heart and the cardiovascular system in general and learn how to name the different anatomical locations. But some of these are important for us to understand what happens during the progress of heart disease, and that's why we need to get familiar with the definitions, the symptoms, and sometimes the causes. And while I'm preparing the course, I found it's really difficult to dive deep into any of these four different criterias where we discuss the physiological manifestation of heart failure, like whether this is a myocardial infarction, where a sudden occlusion takes place and a part of the muscle dies, or hypertension, where in principle there is an increased blood pressure, which is feeding back to the heart muscle, and the heart muscle has to work more and more, so the load becomes higher and higher, and with time this will cause eventually heart failure. Or whether it is, in fact, the heart failure could be a consequence of something like atherosclerosis, where a vascular problem feeds back, and probably it looks like a situation where you have a hypertension, and it could be also a cause for myocardial infarction, and that's in the condition of atherosclerosis. And the last one, which I'm not going to focus so much on it, but I will describe the molecular aspects of the contractile units of the cardiomyocytes, and how would that cause arrhythmias. Okay. At the end of the day, it's very important to understand that what we are studying is to understand the aspects, but we still have to think about how to use these mechanisms in order to get into the clinical usage, and how we could revert heart failure, which is one of the most difficult things to do. Okay, so what is heart failure? So if we make it simple, it's a general aspect of uh, a condition where it could be, as I said, happen due to multiple causes, but the final outcome is that the heart is not going to be able to pump enough blood and oxygen, blood and nutrients to the peripheral tissue. So in this lecture, although we have to remember all the molecular aspects that we described before, and we summarized them in the six main causes of any type of cell injury, uh, starting with the reactive oxygen species, the loss of the ATP production, membrane injury, calcium load, and a couple others like nutrients and change in the lipid peroxidation, for example. So all those convert to cause injury in a cell that then this cell will end up either dying by apoptosis or necrosis because of a membrane injury or other forms of cell death. Practically today in the heart, you have to remember that the loss of these cardiomyocytes or the contractile units of the heart will directly affect the ability of this organ to pump the blood. And it will also signal to the neighboring cells. So we will describe how that signal to the neighboring cells and what the neighboring cells will do. So when the heart is not able to pump that blood, then there is a reduction in the output. So get familiar with these terms. So there's a reduction in the cardiac output. And reduction in the cardiac output means the amount of blood that the heart is pumping in a given time is reduced. Okay? At this point, you could tell that there is an issue in the ability of the cardiac muscle to perform the function. Obviously, it's one of the top causes of illness, hospitalization, and economically, it's very costly. And it's growing in the populations, particularly in the older population. So here's like statistics on males and females. You can see that it prevails more as we age. So heart failure is an aging disease. And as we grow up, you can see the percentage of the population becoming higher and higher with the heart failure. Of course, this could be accompanied with other diseases, which could cause more complicated issues, right? So you can imagine somebody who has diabetes and heart failure to have a very complicated situation. So there is a very nice YouTube video here. I would like to watch it together so it gives you a clear overview over all the discussion we'll have today. So let's go to that together, and then after we will start to crack down the molecular aspects and the anatomical like the anatomical changes in the heart during the heart failure. So let me escape this guy. And okay. I'm sorry, I don't know why the link is not working. So I'm gonna do it manually.
Here's how I keep track of all my tasks. I start by brain dumping everything I need to get done.
Do you see my screen?
Yes.
Okay, thank you. Chat.
Your heart is a muscular organ that pumps blood containing the oxygen and nutrients your body needs. The pumping sections of the heart are the right atrium, right ventricle, left atrium, and left ventricle. In your heart, oxygen-poor blood flows from your body through large veins into your right atrium. Next, your blood moves into your right ventricle, which contracts, sending blood out of the heart to pick up oxygen from your lungs. Oxygen-rich blood moves out of your lungs into your left atrium, then moves into your left ventricle. Finally, your left ventricle contracts, sending oxygen-rich blood out of your heart to your body. If you have heart failure, your heart has lost the ability to pump enough blood to meet your body's needs. You may have weak or damaged ventricular walls that are not able to push enough blood out of your heart. You may also have stiff and thickened ventricular walls that do not allow your heart to fill with enough blood. If you have left-sided heart failure, your left ventricle does not deliver enough oxygen-rich blood to your body, making you feel tired and out of breath. Your failing left ventricle also increases the blood pressure in the blood vessels between your lungs and left ventricle. This increased pressure forces fluid out of your blood and into your lung tissues, which makes it difficult for you to breathe. If you have right-sided heart failure, your right ventricle is unable to contract with enough force to push blood to your lungs. The result is a buildup of blood in your veins, which causes a buildup of fluid called edema throughout the tissues in your body. Over time, heart failure on either side of your heart results in weakened, enlarged ventricles that deliver less blood to your body. To make up for the decreased amount of blood, your nervous system releases stress hormones that increase the speed and force of your heartbeat. Unfortunately, the continued release of these stress hormones makes your heart failure worse because they damage the muscle cells in your ventricles. The most common cause of heart failure is coronary artery disease. Other causes that damage your heart and lead to heart failure include high blood pressure, diabetes, diseased, infected, or damaged heart valves, diseased, infected, or damaged heart muscle, irregular heartbeats called arrhythmias, heart defects, poisons or substance abuse, lung diseases, and breathing problems during sleep called sleep apnea. Treatment for heart failure includes medications, lifestyle changes, or in extreme heart failure, heartbeat assisting devices or surgery. Diuretic medications reduce the swelling in your body by increasing the amount of urine produced by your kidneys. ACE inhibitors are medications that allow your blood vessels to expand. This helps decrease your blood pressure and prevents further damage to your heart by making it easier for your heart to pump blood. Beta blockers are medications that block the effects of stress hormones on your heart. Although beta blockers slow down your heartbeat, they are mainly used to protect your heart muscle from the long-term damage caused by stress hormones. You may need to make some lifestyle changes, including exercising on a regular basis, maintaining a healthy weight, quitting smoking, limiting salt and alcohol, and eating a heart-healthy diet. Surgeries for advanced heart failure include coronary artery bypass surgery to improve blood flow to your heart muscle, heart valve reconstruction surgery to improve blood flow through your heart, and left ventricle reconstruction surgery to remove damaged heart muscle. Surgeries for extreme heart failure include insertion of a device to help your heart pump blood, and heart transplant.
Children in Gaza don't get to scroll past hunger. Right now, thousands of kids in Gaza are going.
Okay, so this was a very good overview. And please confirm again that you see my screen now.
Yep.
Okay. So it gave us an overview on almost all the causes of the heart failure. Some of these we will describe as we progress today. So to start with, heart failure could be starting in a condition where you don't really realize, and this is in asymptomatic, where you don't really realize that the heart failure is the cause of this fatigue or shortness in the breath. But with time, and even if you are doing a little exercise, then you will start seeing signs of deterioration in the fact that you can't really perform the exercise as before. You can't really breathe the same way. And particularly, you have to take into consideration quickly if the heart starts to beat faster. As I mentioned in the previous slide, heart failure is an aging disease. And if you think about it, tachycardia, or beating faster than normal, is one of the important characteristics that we take into consideration, because the heart beats around 65 to 80, depends on the size and gender of the person. The more the heart beats per minute, that's already a stress that you can consider the heart is suffering. Because beating 60 beats per minute compared to 80 beats per minute, this means between these two different personnel, there's 20 beats that are being done. In other words, there's 20 contractions and relaxations. And you will see how laborious is that when we go to the discussion of how the cardiac muscle contract. Okay, so then the end point, and when we start to see edema, that's a point where the heart really needs a clinical intervention. So let me make sure I have the laser. Okay. So the causes and the risks, you have seen them in the video. It didn't, for example, mention the congenital heart defects, and that's in principle when we are born, some of us will have some congenital anatomical changes, and for example, in the valves or in the separation between the atria and ventricles, and those could cause, in principle, heart failure at the long term. One of the examples here is listed for you, the aortic stenosis. And in principle, this is a narrowing of the aortic valve. and therefore this causes a lot of resistance of pumping the blood from the left ventricle. So recall in the video they divided into right and left heart failure. We're gonna focus mostly on the left because the left ventricle eventually has to pump the blood all over the body, and therefore this is the side of the heart which is under the maximum pressure. So if there is any cause that is increasing the overall blood pressure or the blood pressure over the left ventricle, this can be detrimental. So in this condition here, the aortic stenosis, where you have an outgrowth of the valves, whenever the heart is trying to pump the blood, it will have more resistance over the left ventricle. And in principle, the left ventricle has to work harder in order to pump that blood. Okay, so it mentioned hypertension, coronary artery disease. We'll come to discuss those later on. Valve diseases like this, and it will cause regurgitation. This means the blood is gonna be pushed back. And it could be complex, like diabetes. Now we have complex metabolic and heart failure at the same time. Systemic inflammation could cause an inflammation in the heart or in the pericardium around the heart, and that's called myocarditis. And the name myocarditis is the muscle of the heart. Myocarditis is being inflamed. And finally, arrhythmias, where the heart is not going to beat regularly, or the beating is not going to be synchronized across the different compartments. Well, eventually what happens? The heart has to adapt first. So it will first get hypertrophied, and that's an adaptive response. But at the long term, this will cause cardiomyopathy, which means cardiac muscle illness, and therefore failure. So if we look at the heart, as I said, if we cut the heart and look at the different tissue compartments, we will find that this muscle mass is divided into a few layers. The most important for us is the myocardium, because this is the one we focus on generating the force for the pumping. Then there is the pericardium, which is this supporting tissue around the heart. And this is like a sac which protects the heart. And most of the time when inflammation takes place, it affects first the pericardium and then infiltrates back into the myocardium. And finally, the endocardium, as the name indicates, endo is like endothelial. So endocardium is the inner part where the blood is being like in contact with the heart muscle, and therefore these are epithelial cells, which more or less forms a lining similar to any other vessel, like in the intestine. So it's only one thin layer. So most of the time, we focus on the myocardium, which is the muscle mass, and that's where we see the massive death or cardiomyopathy, which could lead eventually to heart failure. And it's worth to mention that, yes, the heart, in terms of the anatomical, from anatomical point of view, that's how it looks like, but this changes from one side to another side in the heart. So the left ventricle has slightly thicker myocardium compared to the right ventricle. That's as I said, because this needs to perform more function. And the arteries are also thinner than the ventricles. That's because they are just like sacs where they don't perform that much contraction compared to the ventricles. Now, if we think about myocardium as a muscle, we have to compare it to the skeletal muscle, which more or less share similar ability in the regulation of the contraction, but at the same time, the cardiac muscle is more specialized. So we will be discussing the differences between skeletal muscle and cardiac muscle. Now, if we zoom in into the myocardium and would like to check what are the cells that reside in the heart. So there are 4 different types of cells that you will find. First, it's the cardiomyocytes. And these are the specialized contractile units of the heart. And these are eventually making a network where the heart beats in a very synchronized way. But these cardiomyocytes exit the cell cycle shortly after birth, meaning the cardiomyocyte will never go mitotically dividing anymore. And this is the essence of the heart failure issues, because whenever you have any insult or injury that causes some of these cardiomyocytes to die, there will be no replacement with another cardiomyocytes. Now, one could say, oh, but we heard a lot about stem cells in the heart. Yes, there are few stem cells in the heart, and their percentage is 0.001. So it is impossible that stem cells could regenerate the heart endogenously, okay? So how do these cells react to injury? Like, call the injury you want and remember whatever we have discussed in this class from the beginning, whether it's reactive oxygen species, which is a mutation, whether it's a loss of function of a particular protein or a gain of function of a caspase, for example, which causes cell death, loss of metabolites, loss of ATP, any of the causes that could lead to a cell injury, it could apply to the cardiomyocyte, of course. But now it's more sensitive, similar to brain as well, that these cardiomyocytes cannot be replaced. And the cardiomyocytes are resistant to cell death. So the first thing they would do is to hypertrophy. In other words, this cardiomyocyte here has received an injury signal, so it has to adapt first. So you can see here, it's already written like pathological hypertrophy, but the first step is an adaptive hypertrophy. And when it becomes chronic, then it could be one of the 2, eccentric or concentric. We will describe this in the next slide. But in fact, this cardiomyocyte hypertrophy, and the hypertrophy is symmetrical, so in both length and width. So this is double of the size in length and width, and that's why we call it concentric. The other type of hypertrophy, when you have eccentric, meaning the cardiomyocyte become bigger but it becomes thinner, and that's why sometimes you see in reports dilated cardiomyopathy. This means the heart got dilated. It looks like a sac, and therefore it doesn't have enough energy and force to pump the blood. This, I would say, the initial response, and at certain point, this becomes converting into programmed cell death or necrosis sometimes, but programmed cell death mostly. And when we start losing these 2-3 billion cardiomyocytes, the more you lose, the less the function of the heart it would be. So the second type of cells is cardiac fibroblasts. And these are non-specialized cells. Normally, they play a role in the extracellular matrix deposition. And when these cells are injured or receive signal like transforming growth factor beta here, these become activated and they look like a muscle cell. We call them myofibroblasts. So cardiac fibrosis is one of the outcomes of the cardiac fibroblast activation, because now this fibroblast become bigger, contractile, and it's able to generate a lot of extracellular matrix. And that extracellular matrix forms the cardiac fibrosis. And this is another form of remodeling of the heart. The third is the immune response. Obviously, if you have cardiomyocyte dying and fibroblast being active, then there are changes in this tissue that will be detected by the immune system. And there will be a rush of the immune cells, which will come to the show in order to take these dead cardiomyocytes away and probably reshape how these myofibroblasts lay down the extracellular matrix. And that could cause further damage to the heart. And finally, you will have the endothelial cells, which could respond to any of these signals from the cardiomyocyte, fibroblast, or immune cells, and they play a role in the propagation of the heart failure later on. Okay, so now we have the 4 different cell types. We're going to go back, just focus on the cardiomyocyte down the road. But this gives you an overview that there is a cell signaling progression that is taking place as cardiomyocytes are the central point, because those are the one which receive the injury signal, feeds into fibroblasts, immune cells, and endothelial cells. And the endpoint here is that you are losing more cardiomyocytes, whatever the reason is, but at the same time, the loss of these cardiomyocytes will need to be replaced at a certain point. So mostly the replacement happened by fibroblasts. So the more you lose of cardiomyocyte, the more you get myofibroblasts, which in principle cannot perform the same function as the cardiomyocytes. So looking into the different cell types is one thing, and looking into the different compartment or systems in the heart is another thing. So the previous slide described the myocardium and what are the type of cells and how much we have each out of each of those cells and how do they communicate with one another. But bear in mind that the heart is also responsible to propagate an electric signal. And this electric signal has to be synchronized. And therefore, issues with the arrhythmia could come from a myocardial issue or injury that feeds into the conduction system, or the other way around. It could be the conduction system where these specialized cells for conducting the electrical output get defected, and then the electric signal will be not synchronized. Okay, I'm not going to describe the anatomy of the conduction system and how the pulse go from one side to another side. That's pure anatomy. I'm not going to be having time to go through that. And finally, yes, the myocardium have specialized cells which initialize the conduction, and the electric signal could, in principle, propagate in the heart. But at the same time, it has also to feed into the signals that come from the nervous system. I mean, I don't have to tell you how complicated the heart compares to all other tissues and all other organs, because you could already tell issues in the heart could feed into the liver, into the kidney, into the lungs, into the cardiovascular system in general, all the vascular system. Now add on top the nervous system, because the heart could increase or decrease the amount of heartbeats per minute based on signal that the brain dictates. And that's what you've seen in the video by the release of the signals from the brain, like catecholamines and such. So, but don't mix between these 3 different systems in a way that the heart doesn't really need the brain to contract, but the heart would contract slower or faster based on a signal from the brain. What's the proof of that? The proof is that it is known that when the heart is taken out from a patient in order to be transplanted to another, the heart continue beating. And therefore, during this time, there will be no nervous input. It will be only the myocardial conduction system, which is responsible for that. Therefore, the contraction of these specialized cells in the heart is endogenous. It's from the heart itself. But yet, it responds by going faster or slower by signal that comes from the nervous system. Okay. So this is the form of adaptation that we discussed. That the first site of adaptation is that this is a normal heart and that's an hypertrophied heart. You can tell clearly that the size of the heart is bigger, the thickness of the ventricles are bigger. So this is a transverse section. And if we look at the individual cardiomyocytes, you can see that some of these cardiomyocytes are 4 or 5 times compared to the regular ones here. So this is an adaptation process because the heart is trying to keep the cardiac output at a regular level. So there is an injury, we are losing cardiomyocyte, but we still need to have a stable cardiac output. What does that cause? It causes cardiomyocyte to become bigger so that you can maintain this cardiac output. You keep doing that until the hypertrophic response becomes so high and it's a chronic process. So the cardiomyocyte cannot become bigger anymore. So that's when they started dropping out and dying. And that's the problem, because look at this slide here and imagine that this cell had an injury and it died. So you can imagine that there are few fibroblasts that need to come and replace this. But can you look at this one here? If this one dies, eventually there is a big gap in the in the ventricle that will be left out without cells, or not without cells, without contractile units. And therefore, you can imagine that the more of these will die, the more of replacement that will take place, and therefore less cardiac function. Okay, so we defined already the cardiac output, and simply put, you can define it as how many beats per minute and how much volume of blood you eject. So if the number of beats become higher and you are stroking or ejecting a smaller volume, you can still have a good output. And that's one of the adaptations you've seen in the video, that the heart becomes to beat more and more and more, because instead of beating 60 beats per minute, now it's beating 80, because instead of ejecting 100 ml, for example, of blood, it's ejecting 80. That will cause cardiac output to become stable, but for a short period of time. But if we take the condition that the heart rate didn't change and the stroke volume get down, so that means if you are beating only 60 beats per minute and the volume is going less and less, this means the cardiac output is going lower and lower. And that's how we define that the heart is going to the failure phase. So that's another way how we look at the cardiac output. Now, there's a definition here for you. It's called ejection fraction percentage. And this is defined to be the fraction of blood that is ejected with every heartbeat. And in normal people, it's 50 to 70% of the blood that is being ejected. I will just give a rough example. 100 ml of blood, you eject only 70% of it, which meaning 70 ml, because the heart doesn't go totally empty. There will be a residual volume there. Now, why is this important? Because in clinic, that's what they measure by echocardiography. And if this drops lower than 40%, this means the cardiac muscle has an issue and is not able to sustain an output that eject this blood. And therefore, it indicates systolic heart failure, which means contractile. Systolic is the contraction, which indicates a systolic heart failure. Okay? Now, the hypertrophic growth that we are talking about here, as I said, is strictly adaptive in the beginning, but it's also responsive. It's responsive for immune signal, it's responsive to contractile signals, and it's responsive for whatever is happening in the heart. And it's a compensation process. But at the long term, this will eventually cease because it cannot continue to compensate. Okay, so this is just a general summary for you about the cardiac output, and it shows you how complicated it is to change or regain back the function. So there are many other factors that affect the cardiac output. So in the previous slide, I make it so simple. It's the volume and it's the heart rate. So how much volume we're ejecting, how much beats the heart performing per minute. But the heart rate or the beats per minute, as I said, it could be reflected by many other factors, like hormonal factors, arterial receptors, neuronal complexes, nervous system. All that causes the heart rate to go up and down. Like simply, if you are at night in dark and you got afraid, your heart rate to go higher. That's mostly a central nervous system, an autonomous nervous system. Similarly, increase in the hormones like insulin could be a cause of the increase of the heart rate. On the other hand, the stroke volume or the volume of the blood that you are ejecting, that can be affected by multiple parameters. Like one of them could be the myocardium itself. Is it healthy? It's getting enough oxygen. It could be nervous, like it's stimulated to beat more. And it could be related to the volume itself, meaning if I'm ejecting blood, okay, and there is a problem in the valve, then there will be a venous return issue or aortic return issue, because it was described for you in the video that if there is a problem in the left ventricle, then the blood coming from the lung to the left atria will have an issue to go down to the left ventricle, because eventually the left ventricle is not empty. And that is what we call preload and afterload. So this is something is really purely clinical. I don't want really to ask you what is preload, what's afterload, how you define between the two, but it's just showing you the fact that stroke volume can change drastically based on every single beat in the heart, depending on the atrial function, ventricular function, aortic function, as well as the feed-in of the myocardium and the central nervous system. Okay, so which brings us to the main cause of heart failure. So this is the consensus cause of heart failure, which is the loss of the myocytes. So these cardiomyocytes are normal, happy, and they have in between some endothelial cells and fibroblasts. Now they got injured. Some of these cardiomyocytes, as you can see here, they are not healthy anymore and they will die. When these die, they will be replaced by cardiac fibroblasts. And in order to replace them with the cardiac fibroblasts, we have to activate these cardiac fibroblasts, because first we need these fibroblasts to divide, and then we need them to generate this extracellular matrix in blue because we can't keep the heart with empty spaces. Something has to fill that space. And since we don't have any specialized cardiomyocyte that will come from a mitotic division, then the only best bet we have is that these fibroblasts divide, become a bit bigger themselves. They will become more visible. As you can see, they were like more stuck in spaces here. They become more visible. They become bigger fibroblasts. And at the same time, they generate the extracellular matrix, which filled that space. But now, this cardiomyocyte was contracting in synchronized mode with the rest. What happened here is that these two cardiomyocytes, they still have a very good contact, but they lost the good contact with the rest of the myocardium here because that's a lot of replacement fibrosis that took place. And therefore, this could cause the generation of the arrhythmias. Okay? What I have mentioned here, it's written in text for you, and it describes the steps as cardiac hypertrophy as an initial step, and then going to an adaptive response, which ends up to maladaptation in eccentric versus concentric growth. And finally, the process of cardiac fibrosis as cardiac fibroblasts become active and lead to the induction of the number and replacement fibrosis that replaces the cardiomyocytes. Now, there's one point you have to keep into consideration. Although the heart is contracting, it has to relax in the same synchronized way. So issues in having the heart not able to contract, like here, because you lost contractile units, could be also reciprocal to cause diastolic dysfunction, because if this myocardium here contracts, the contractile units are less, so the contraction is less, so the force is less, and therefore the pumping of the blood is less. But at the same time, after this contracts, it has to relax back, and this replacement fibrosis could cause diastolic dysfunction because the heart is more stiff and is not able to relax. And this brings me back to this slide because it tells you that the end systolic volume is high, meaning after the contraction, okay, and after the relaxation, so here you have the end systolic volume. So you ejected the maximum amount of blood, but you still have high volume after the contraction. On the other side here, you have end diastolic volume, meaning after the relaxation of the heart, you have a higher volume. And this could be a cause that, as if you are going to fill a room that is already filled. Like you get to a hall where there is like 500 seats, there's no seat. And that's eventually the main cause of diastolic dysfunction. The heart is not relaxing enough, therefore is not allowing the blood to flow from the atria to the ventricle because there's no room. So that's another form of heart failure causes. Okay. So more about the eccentric versus concentric remodeling. So both of them are hypertrophy. In other words, the cardiomyocytes receive signal that they need to adapt to a low cardiac output. What do? They need to increase in size. But now, how do I increase in size? Is it in a symmetric way where I can add the cytoskeleton both in width and length? Or am I adding these cytoskeletal units, the sarcomeres, only on one side, so it goes parallel? So if we go to the concentric form, I would say this is easier because it starts as an adaptation, and this cardiomyocyte looks like double the size of that. But the issue is if we continue adding those, the diameter of the heart becomes smaller. Because you're adding more, you're getting a thicker wall so you can make more contraction. But unfortunately, you are invading the space of the heart. So the interventricular diameter becomes small. And therefore, this heart can carry more volume than that heart of blood, right? So you cannot have enough blood in the ventricle compared to the normal situation. So the main cause of the issue here is that less blood is being ejected. Okay, because the availability of the blood, so there's less volume of the blood. Okay, and this causes what the type of heart failure that normally gets. It's heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction. They call it HFpEF. Like in the future, I'm sure you will come across this in your medical studies or in the pathophysiology. The second type is the eccentric, where the cardiomyocyte hypertrophy goes parallel. And now you don't really get a thicker wall. So there's less power that this ventricle can generate. Less force, I'm sorry, let's generate. But at the same time, you get a bigger diameter. So the heart dilates. Okay, so this causes heart failure with reduced ejection fraction. What does it mean? Because now compare the volumes. 100, 50, or 60, and 180. I'm just adding like an example, rough numbers. So in this situation, because the muscle is so well generated thick, it can eject really well the blood, and therefore the ejection fraction is preserved. But in this situation, the ventricle is thin, so it cannot generate the power and the force. And the volume is already high because there's a dilation. Therefore, this will cause heart failure with reduced ejection fraction. And in both cases, the long term, this can cause the heart failure. Okay, so this is described for you as well here. If you have any questions about any of these terms, please come back to me. The most important to remember is the way that the sarcomeres are aligned in these two situations, where it goes in series in one condition and in parallel in another condition. And that could eventually cause heart failure. Now, this is a purely hypertrophic response. We didn't discuss that there's a loss of oxygen or coronary artery disease or diabetic. This is purely an effect over the cardiomyocyte units themselves. Okay, so look at this and think about how complicated it is to discuss the preload, afterload, and the oxygenation at the same time. The preload and afterload means the volume before and after the contraction of the heart. And think about that whenever issues show up at the left ventricle or the atrias, no matter what, it will feed back into the lungs eventually. And that's why we always take into consideration looking at the lungs whenever there are any signs of heart failure, because we want to see if there's any accumulation of liquids in the lungs, as well as we want to see the pressure that we normally expect to get higher when there's any left or right ventricular problems that could feed back to the lungs. Okay, I'm not gonna go to this, and I'm just giving you this as a further reading. I'm not gonna go into the lung issues in this lecture. Probably if we have time, we would come back, or if somebody is interested, I will be more than happy to describe those. But in this lecture, I don't really have time to go through that. Okay, now, what is systole and what's diastole, and how much time it takes the heart to beat? The relaxation is defined the diastole, where the blood fills the ventricles. So the first thing that happens after that contraction is it will relax. And this relaxation is the cause which allows the blood to flow from the atria to the ventricles. Yes, at the end of that step, the atria has to contract. So it empties whatever blood is there in the right and then in the left. It goes down. And then the systole is the contraction when the ventricles eventually eject the blood either to the heart, either to the rest of the organs or to the lungs to get oxygenated. Okay, this is also synchronized in terms of the conduction system. And it's very well aligned for you here. So you can watch this many times and you can tell what is happening during each one of these steps. So first, if we take the cycle start at any of those, you will clearly see that the synchronization of the atrial relaxation happened in both right and left. Relaxation of the ventricle happened the same time on right and left. And then ventricular contraction both at right and left, as well as the atrial contraction on right and left. What does this tell us? So it's important to think about the synchronization of that contraction in parallel to what we have seen in terms of the hypertrophic response and the cell death. Because now, if the signal gets to the myocardium on the left ventricle and we have that issue, then the propagation of that signal will not be normal. Okay? And this is why we use ECG to detect cardiac failure or changes in the heart or arrhythmia in general. So that's one of the ways that we could detect signs. Excuse me 1 minute. Okay. Sorry, I just got a message. 1 second. Okay. Okay, so the other aspect that we were introduced in the video was the valves, the function of the valves. And eventually the function of the valve is very important to prevent the blood to flow back. So one of the things that happens when a valve has a defect is that the separation between the ventricles. So here you have a transverse cut, but you're looking from the top of the heart and you're seeing the tricuspid valve and the bicuspid valve. So if there is an issue in the tricuspid valve, as you can see, then the blood can flow back between the left ventricle and the right, the left ventricle and the right and the left atria. And therefore, this causes an increase of the blood that resides in the left ventricle. And this is mostly what we call incompetence or regurgitation, because there is a distortion in that valve, and this permits the flow back the backward flow of the blood to take place. Now, these days we can have surgeries and replacements of valves, which is something really amazing. But at the long term, patients with valve disease, they might need another type of surgery to perform, like every period of time, a replacement. Okay. And finally, as I said, we are not going to describe the anatomy of the contraction at the level of the electrical conduction and how the signal goes and how it's synchronized and all that. But we want to use the information we read out of this electrical conduction and synchronization of the contraction to understand how the heart works. And we will look into the electrocardiogram at the end of the lecture in order to understand how to differentiate between a normal and an abnormal cardiac contraction. So what is the depolarization and the polarization? So these are the two terms that we have to start knowing. The word depolarization, it means that something is already polarized and you are depolarizing, so you are bringing back to normal. Is this the case? Yes, because our cells, they maintain some sort of threshold of positive and negative ions. And the repolarization process is to bring it back to that value, whatever it is. It's like, this is something we measure in millivolts, and I will describe it very, very carefully. So I want you to understand it because it goes both in skeletal muscle and in the heart. Now, when we read the signal that comes from the electrocardiogram, you will see the P wave, which is called atrial depolarization. Atrial depolarization. So this means you are causing the contraction of these atrials. After changing in an action potential, the depolarization takes place. And that's where you measure the atrial contraction. And then the magnitude of this is really small because the value you get for the QRS wave, which is the ventricular contraction, is much higher. So the magnitude is just higher. And that's when we have the ventricular depolarization, which means the contraction of the ventricles. Okay, now within this high peak of ventricular depolarization, there's another signal that is masked, which is called the atrial relaxation or repolarization. But we can't see it because now we see the high peak for the contraction of the ventricles. And the T wave represents the ventricular repolarization, meaning bringing this back to normal. Okay? Now, in terms of time, this happens within a second. So electrocardiograms are important to see in shape, how they look like, how the signals look like, and also in terms of their timing. Because if there's a delay, that would tell you if there's a delay in the T, there's a relaxation problem in the ventricles. If there's a delay in the P wave, this means there's contractile issues on the atria. So the shape of the electrocardiogram is one thing, and the pattern of how many PQRS you're getting, and if this value is changing, as well as the timing. Okay? So how do we get into that? So there are a few definitions for you here. Depolarization is the movement of membrane potential toward more positive potential. Depolarization, this means, as I said, it was already polarized and I'm bringing it back to normal, which is the positive potentials. The term hyperpolarization, meaning you are exciting it more, movement of the membrane potential more toward the negative potential. And maybe now you don't really realize why I'm saying positive and negative, but in the next couple of slides, you will clearly understand. And when you say repolarization, you bring it back to the normal, to the number it was before the depolarization, whatever that number was. It goes back to the normal, which is minus 70 millivolts. Okay. And this is something I already mentioned, that the heart rate, depending on, of course, the conduction system, but also it depends on the nervous system as well. So the contractile unit of the heart really have the endogenous contraction, but they could become faster with the sympathetic stimulation or lower in frequency in the parasympathetic. And if we have a change in the synchronized beating and changes in those electrocardiograms, then that's when we start discussing arrhythmias. Okay? And the type of arrhythmia is depending on this anatomical side. So when you speak about supraventricular arrhythmias, it initiates somewhere in the sinoatrial node or the atrioventricular node. When you speak about ventricular arrhythmias, this is mostly in the ventricles. So these are pure terms that describing what is really happening at ventricles, atria, and it becomes more and more complicated as you go to the clinical side of it. A very well-known notion is defibrillation, which is mostly used in the atria. The atrial fibrillation is one of the causes that many patients suffer, where the synchronization between the right and the left atria is lost, or within the same atria, one side contracts faster than the other. It gets more and more complicated to discuss all these types of arrhythmias. I'm listing them for you, and you can read through them. And if you think you will be a cardiologist in future, please follow up on those. Okay. Which brings me to close the discussion about the cardiac cycle, and this will be the last slide. Obviously, you will need 3 lectures to really digest what exactly happened at every step at these 4 different conditions here in one cardiac cycle. Because cardiac cycle alone, it needs like an hour lecture. But it's important for you to integrate those information in a sense that cardiac cycle, although it's 1 second, where atrial contraction, if we take it as a start point, well, the blood comes over to the heart from the vena cava, from superior and inferior vena cava. It gets to the atria, the right atria. The right atria is filled with the blood, and now it's the time to get filled and filled and filled more. So my slide is not working. So it becomes filled with that blood. And you keep adding that blood freely going into the ventricle before atrial contraction starts. The last step of that is, in principle, the contraction of the atria, which it eventually empties up as much blood as possible, and then there will be a close of the atrioventricular valve. Now you have almost empty atria and almost filled ventricle. And now you shut that valve. So there's no coming back. Then it becomes where the heart has to contract at the ventricular part. So the contraction of the ventricle will pump the blood either to the lungs or to the body. And now at the end of that ejection, the volume in the ventricle becomes very small. Okay? And that's what I mentioned before, that when you eject the blood and you contract to the maximum, you need to go to a relaxation step. And that relaxation step is the diastole, or the relaxation of both ventricle, that allows again the blood to start freely coming from the atria back to the ventricles. So this is if we take just one ventricle and we describe it. But on the other side, you can see massive changes in the pressures, changes in the volumes, beating, and all that. And this is referred for you in page 555 in the book. Please go and read it. This is not part, I'm not going to ask you what are the steps of the cardiac cycle and describe what's happening. This is not something I'm going to do, because this class is mostly focusing on the molecular aspect, not the anatomy or physiology. Okay, so we'll take a break, and it's going to be a short break today. It's going to be only 10 minutes. Please come back by 10. And I will pause recording. Anitra, the quiz is at 11. Okay, just give me 1 second. I'm just trying to see if Brightspace is showing everything as it should for the quiz. No, there's not an open book. This quiz, as mentioned, it's gonna be more like proctored. Today, Brightspace is not fun. It's not showing some details. Mm. Okay. I think you should see the quiz on your end. But we're not starting the quiz. You can't access this before 11 anyway. So don't waste your time now by going to that. So let's focus on the next 50 minutes on the class. And then we switch to the quiz. Don't get so stressed. It's just a quiz. Come on, you did more difficult than that. So let me resume recording. Resumed. Okay. Close that. And I'll share again PowerPoint. Okay. So let's dive now into the molecular aspects. How do we see changes in oxygen, in ATP, in nutrients, or receiving insults like oxidative stress or cytokines? And how do our cardiovascular system react to that? Like this slide we already discussed before, if you remember, when we described the ischemia reperfusion injury, where reactive oxygen species are generated and cause the necrotic effect on the cells. So think about this necrosis happening in the cardiomyocytes and how detrimental that would be to the left ventricle and to the contractile forces being generated. But this could be also an issue because it can have a vascular outcomes. And in this slide, it's mentioned atherosclerosis, which is one of the most common or known causes of vascular issues, where a process of inflammatory response that could be triggered either by endothelial dysfunction or an immune attack or an elevation in the lipid peroxidation or a shift in the levels of the lipids of the in the body, all that could encounter one with another to cause this changes in the vessel wall that eventually gets to a change in the diameter of that wall. So in principle, the outgrowth here, it shows you that there is a collapse of that vessel. And eventually, this will cause resistance of the blood flow. So when this happens, this will make the left ventricle work more and more, because the thickening of this vessel is an occlusion, and that occlusion is feeding back more pressure over the left ventricle. So this could be the cause of the start of the left ventricular issues, starting from the fact that the heart is always under pressure. So we'll go first to describe decontraction, then we will come back to this one more time. Okay, so which brings us to how do these cardiomyocytes contract and how these cardiomyocytes are different compared to the regular skeletal muscle. Well, one obvious difference between skeletal muscle and heart muscle is the voluntarity of the contraction. You can decide anytime to contract your skeletal muscle, but not the heart. The heart is typically running on its own. It's autonomous. The other thing is that the connection between skeletal muscle and cardiac muscles, muscle fibers is different. So in myocardial cells, there is a there's a continuity of this network through what we call intercalated discs. Okay, this will allow a rapid propagation of signal and information at the same time across the cardiac muscle. So these junctions that are formed between the different cardiomyocytes that we call intercalated discs, they maintain a faster response. Now, you know, biologists, they like to give different names for things, and today, for example, you are introduced to a new, like the cytoplasm, we call it sarcoplasm, the membrane we call it sarcolemma, the cytoskeletal we call sarcomeres. This is different naming. There's nothing really that you have to worry about, but you have to still remember those names, unfortunately. Now, the muscle fibers are aligned one with another in conjunction, where they form what we call reticula, sarcoplasmic reticuli. So these are aligned in a way where you can get access to components you need for the contraction to take place very quickly. Because think about it, this is a contractile of less than 1 second that is taking place, right? And therefore, it's a very laborious process, and it should be very synchronized and organized. And you would need this to happen across 2 billion cells, then the propagation has to be excellent. On the other side, we have what we call the T tubules, which would maintain, excuse me, the structure where you have the propagation of the contraction across different cardiomyocytes. So let us see first how the sarcomeres are made and how the contraction in regular muscles take place, and then we will differentiate that between skeletal muscle and cardiomyocytes. Okay, so if you get into a lab and you have a cardiac muscle compared to a skeletal muscle, you can quickly by histology look at the two and you differentiate, because in principle they both have sarcomeres, but the organization of these sarcomeres are different. And here I'm introducing you to the first concept, which is the need of the calcium. Both muscles need calcium. Of course, there's a smooth muscle which is not presented in this class, but also it requires the calcium. But where did you get this calcium is different between cardiomyocyte and skeletal muscle. Okay, now cardiac muscle, they really need the supply from outside. Most of their supply comes from outside, while skeletal muscle and smooth muscle, they mostly utilize the sarcoplasmic reticulum calcium, which is the calcium they store inside. And that could explain why the propagation of a signal is different. Okay. Now, the other thing is that how these sarcomeres are aligned, you can quickly tell that in the cardiac muscle and in the cardiomyocyte, they have alternating fibers of thick and thin, and this causes the appearance of thick bands and thin bands. But now the components of the contractility, they are more or less the same. Okay. So the two big differences between striated muscles, skeletal muscle, and the cardiomyocytes. The first is that the cardiac muscle, they transmit the action potential quickly from one cell to another, and that is mostly maintained by what? By the intercalated discs. Okay, so that's very important structure that cardiac myocyte have compared to skeletal muscle, because they need to have the quick response of the action potential that propagate from one cell to another through these intercalated discs. And those intercalated discs will play a role, of course, in the calcium which is needed for that contraction. The second is that they maintain high levels of energy synthesis. The cardiomyocyte, they cannot cease contraction. They have to contract every single second. So they need to maintain reserves of energy and generation of lots of this energy. And that's why the processes we described before, the fatty acid oxidation and glycolysis, which happen in the mitochondria, it's not surprising that around 25% of the cardiomyocytes are, in fact, mitochondria. Okay, so that could project into two things. First of all, it's going to tell you that the calcium load, which is mostly outside of the cell of the cardiomyocyte, as I mentioned here, is very important. So the shift in the balance of the calcium could be detrimental to cardiomyocytes. And the second thing is lots of mitochondria, loads of mitochondria for ATP synthesis. And therefore, they are more prone to generate reactive oxygen species, of course, because this is not free to generate ATP without reactive oxygen species. So you could imagine an oxidative stress could be also detrimental to cardiomyocytes, because if there's a shift to more reactive oxygen species generation, then with this amount of mitochondria, the cardiomyocytes are gonna suffer, and they would really get to an injury level. Okay, so let's first discuss the main concept of action potential and the contraction, and then we go back and project it on the cardiomyocytes. Okay. The membrane maintains a difference in the concentration of the positive ions and negative ions. And normally it's a negative ion that is concentrated inside the cell compared to the outside of the cell. So if we measure the potential in between the inside and the outside, or across that membrane, then there's more positive outside compared to the negative. And this is a net number that, when measured at a resting stage, so a resting membrane potential, is that it has more negative ions inside compared to the outside. So that's what I mentioned is around minus 70 millivolts. Now, the propagation of a signal between a nerve and skeletal muscle, it goes probably similar. We are here describing the skeletal muscle. So the skeletal muscle is normally, well, the cause of the stimulus is different from one cell to another, of course, because the acetylcholine is the main depolarizer in the nerves, and here it could be the calcium. So how is this maintained? The voltage difference is created by unequal distribution of the ions. So you can see that there's more sodium outside compared to inside. So, and more potassium inside compared to outside. But how is this maintained? This is maintained, of course, by sodium-potassium pumps, because this is a pump that whenever it pumps 2 potassium inside, it pumps 3 sodium outside. So automatically you are shipping 1 more sodium with every pump. So that's the aspect of the pump itself. Now, on the other hand, the potassium can freely diffuse through the membrane outside, making more of that potassium to go out. So there is more positive being transmitted from inside the cell to the outside, which causes more negativity that we are talking about here. And at the same time, the diffusion of sodium is more difficult. So there's little of that sodium that diffuses free. Sorry. So all that causes a more negative charge inside the cell compared to outside. And remember, in previous classes, we mentioned also is the same case for the calcium. Intracellular calcium is low. Calcium is positively charged too. So if we take that membrane and we measure the electric pulse or the electric signal or the resting potential, call it, when you eventually get to a level that there's more negative charge across the inside compared to the outside. And that is what we call the resting membrane potential. Okay. Now, as I said, nerve cells and muscle cells, they have different signals that change the membrane potential or stimulate the membrane potential. What happens next? If we go for depolarization, meaning you are changing the shift in the balance of the ions, and in other words, you are rushing more positive into the inside. That's what we call depolarization. Therefore, you will have more of these sodium getting in with the arrows inside. Okay? And it's depolarization, meaning you are changing the balance of the membrane resting potential. Okay? That's the change of the membrane resting potential. Now, you need a stimulus that is exceeding a threshold. Oh, sorry, the slide kind of overlapped here. I will fix it. So you need a stimulus of around 15 to 20 millivolts that could make this change to happen. Okay, so that rapid change is around 15 to 20 millivolt, and this is what we call the action potential. Okay. Now, in order to restore this back, this is the depolarization. The depolarization, this means the sodium-potassium pump has to work out in order to ship as many sodium back, diffuse as many of these sodium out. This is at the end of the signal. So whenever the stimulating signal is gone, then the sodium-potassium pump has to restore the resting potential and bring it back to the level of how many negatives compared to the positive ions we have across the membrane. So this is what we call the depolarization. There is an important notion you have to remember is that the 15 to 20 millivolts are just needed to excite the membrane. And once it happened, the stimulus, it can propagate without any further stimulation. Like the membrane potential, it can go across the membrane all over with no further need for another signal. Okay, so at the depolarization compared to the repolarization, sorry, compared to the depolarization, now you are rushing these positive ions outside and bring it back to the resting potential. So it goes back to the normal situation. I'll fix this slide where it's overlap, but it's very well tailored for you here. Okay. I just mentioned everything. It's like already there. So let's bring calcium to the show. Remember in these slides, we described the level of calcium is going to be much lower inside the cell compared to the outside. And that's due to the fact that calcium cannot freely come in unless it's organized by channels. And once it gets into the cell, calcium is chelated by proteins and then sequestered in the mitochondria and in the sarcoplasmic reticulum, endoplasmic reticulum, okay? So, which means in skeletal muscle, we have a reserve of calcium that is sitting here, waiting a signal where we can release this calcium in order to use for the contraction. While in cardiomyocytes, we need this calcium to come in and then release the reserves in the sarcoplasmic reticulum, then cause the contraction. Remember that increase of the cytosolic calcium could be detrimental, and we discussed activating multiple enzymes that could cause nucleus damage, membrane damage, and lower ATP synthesis. So it's important to have this delicate concentration of calcium being under check, and the changes in the levels of the calcium in conditions like ischemia, which is one of the causes of heart failure, because you can imagine that the loss of the blood feeding into the myocardium will cause ischemia, and then a shift in the calcium level, and that all happens in the cardiomyocyte, and therefore the cardiomyocyte will be dying. So this we already discussed. And then this also we discussed in the module 6, how the organization of the calcium, how it gets in, how it gets sequestered with certain proteins. So all that we come into practice today by discussing the effect of that on the contraction. So how does this happen? So as I mentioned, we have the skeletal muscle compared to the cardiac muscle. The skeletal muscle will need an impulse that comes most of the time from the nerves at the neuromuscular junctions, right? And this will need acetylcholine to propagate that signal into the skeletal muscle myofibers. And then this will trigger the action potential, which means this 15 to 20 millivolts that we discussed, that will trigger the signal where you can change the amount of the sodium, potassium across the membrane, and therefore change the millivolts across that membrane, or it causes its depolarization. Okay, then the action potential travels along the membranes and the T-tubules. And the last step would be this signals to the sarcoplasmic reticulum. So the T-tubules is connected to the sarcoplasmic reticulum, where it causes the calcium release. And that calcium release into the cytoplasm, where it causes the contraction. Okay, the process of binding of calcium to the cytoskeleton is going to be in the next couple of slides. On the other side, we have the cardiomyocytes. the cardiac muscle. Now, the action potential now is voltage-gated calcium channels. Okay, so it's really depending on the voltage-gated calcium channels. So whenever the cardiomyocyte receives the signal, it has a small amount of calcium that gets from the cell, from the extracellular space. And that little amount of calcium is the trigger to release the rest of the calcium from the sarcoplasmic reticulum. So here, the signal gets into the T tubules and then releases that calcium from the sarcoplasmic reticulum. Here, the entrance of a small amount of calcium through the voltage-gated channels after receiving that signal then causes the entry of that calcium into the sarcoplasmic reticulum. And it triggers a very important process that you really have to remember. It's called calcium-induced calcium release. Calcium-induced calcium release, meaning the cardiomyocytes are in continuous contraction. That continuous contraction depends on the availability of calcium. That availability of calcium is through the voltage-gated calcium channel. So it lets a known amount of calcium to enter to the cardiomyocyte with every single beat. And that little amount of calcium enters to the cytoplasm and release calcium from the sarcoplasmic reticulum. That's why it's calcium-dependent calcium release, calcium-induced calcium release. And now calcium comes from both inside and from outside of the sarcoplasmic reticulum, which causes the contraction of the cardiomyocytes. Okay. How do the cardiomyocyte contract? So we have the myosin and the actin, which is similar in both cardiomyocyte and skeletal muscle. But the myosin, it has these two molecules that are normally bimolecular, and they have what we call the myosin heads. And then a bundle of those will make the myosin microfilament. So you see that there's a filament, which means many of these myosin molecules with multiple of these myosin heads. And on the lower part, we have the actin. So now, just to remind you that myosin is called the thick filament and the actin is called the thin filament. On the other side, we have the other component is the actin filaments, which is explained in the next slide. So you see the T tubule here. It is playing a role in having that calcium propagating for the contraction to take place. Now, let's go back to the myosin and to the actin. Okay? So you have the actin in the blue, and you have the myosin in the green. And you have the T tubule, which comes across the membrane and the sarcoplasmic reticulum. Okay, so now, where is the role of calcium in that contraction process? The availability of calcium is important to allow the myosin and actin to contract, or in other words, to interact with each other. So let's start from a resting state. So in a resting state, the calcium ions are stored in the sarcoplasmic reticulum. You received a signal or a stimulus, it propagates through the T tubules, and now it signals and causes the release, the action potential that is received through the T tubules. It causes the sarcoplasmic reticulum to release the calcium ion. So we got the signal, it propagated through the T tubules, and now reached the sarcoplasmic reticulum. The sarcoplasmic reticulum released the calcium. So that's the next step of the process. But now let's look how actin and myosin do perform in the resting state. So in a resting state, the myosin binding site are covered by troponin and tropomyosin. So we have the actin filament here, and you have the myosin filament in green there. In a resting state where it's not contracting, the actin binding site are covered with a protein called the troponin and tropomyosin. Okay, troponin, and this is troponin and tropomyosin. Now, when calcium is released after receiving the signal, calcium will bind to troponin. The binding of calcium to the troponin, it will make it slough off the compound, and therefore it would make the actin accessible to changes. So troponin is going to be released, and the actin tropomyosin now will change conformation. The change of the conformation between tropomyosin and actin will cause these myosin head find their docking state in the actin. And therefore now myosin and actin could interact, and that's how the contraction starts. So if we go one step back, without calcium, this is not going to happen. And with low calcium, the contraction is going to be not good. And therefore, loss of calcium is known to cause these cramps in terms of muscle contraction. So now there's one last component that we didn't describe, which is the ATP. The ATP. So what is the role of ATP in this process? Obviously, ATP is the energy producing molecule, storing molecule, and that molecule is going to come to the show to change conformation of the myosins. This change in the conformation in the myosin through the energy from the ATP, that's how it drags the actin back and forth. Okay, so this will be described probably in the next slide. So the myocardial relaxation process. So wait, so in this process, yeah, so that's described here in the relaxation process. Now, let me go one slide forward and describe the role of the ATP, and then I come back to the relaxation. So what we are seeing here, a resting state, right? So the cross bridging between the myosin and actin is not taking place. Okay, and you can start the cycle wherever you want. You can start at the end of the relaxation or at the start of the contraction, whatever you want to call it. But here, the idea is that the ATP binding to the myosin, it will cause the myosin to change the conformation. So that's what you see in the first image. The ATP is binding to the myosin. So whenever ATP binds to that myosin, it will change the conformation based on the energy that has been transferred from the ATP to the myosin. And this will, you see it here, it's kind of change in the conformation of the myosin. Okay? Now, in the presence of calcium, so we prepared by ATP the ability of myosin to bind to actin. Now, on the other side, the calcium is going to come and bind to troponin and take it off, and then change the conformation of tropomyosin. So you see these dotted lines here, these were the tropomyosin, and that's the actin. So calcium came in, bind to troponin, troponin changed conformation, sloughed off, and then now the tropomyosin changed conformation. And in this change of conformation, the myosin can use that energy of ATP to bind to actin. Okay? But yet, so this is happening like instantly. I'm describing it at steps, but this is happening instantly, all those four at a second. So now we have myosin get access to actin, and it has all the package of ATP, which now is represented as ADP plus PI, bound to that. Okay. Now, when you hydrolyze the ATP, so you break down the ATP into ADP and PI, this is the energy that is 100% transferred to the myosin. And now it drags the actin. And that's how the contraction takes place. So the generation of the ATP from the mitochondria is absolutely important for this process. The availability of the calcium and the maintenance of that level of calcium is absolutely important as well. Now you could tell that mutations or changes on the conformations of actin myosin, as well of cytoskeletal proteins in the cardiomyocytes, are very, very important. And that's why, probably I didn't present it in this class, but I will present it in the next one. Mutations or changes in the levels of myosin heavy chains are very well known to cause cardiac myopathy. Okay. So all that is written for you here for further reading. If you have anything, please let me know. And now we come back to this process. I hope this is now better understood for you in terms of the propagation of the action potential. So you eventually changing the shift from a negative to a more positive. You are minus 70 millivolts. You're going to close to zero to a neutral situation when you do depolarization. And that's the contraction of the atria. And then the same thing when you do it in the ventricles, but now it's in a higher magnitude. And when you do the repolarization, that's when you go back to a more negative value of the membrane potential. And of course, now we can tell that the changes in the cardiac function could be read as an outcome that could tell us there is a change in the propagation of the signal, and therefore the contractility of the ventricle is affected. So in conditions where coronary vasoconstriction happened or occlusion, this means there is a site, and first of all, coronary arteries and veins are the vessels which provide the cardiac muscle with the nutrients. So if those are occluded, then the myocardium is going to be suffering from lack of oxygen and nutrient. And this we could easily detect in the electrocardiogram because there will be some shifts in the S to T waves because the electric conduction at this point is shifted. And you can tell that the electrical depolarization is mostly correlated to the ischemic issues. So there's another example that I posted for you here. Here. So whenever there's an ischemic region, so you can see that the repolarization here is shifted in conditions of ischemia. And if there's a massive injury, there will be a massive change in the repolarization process. Okay. And then we come back to the issues in the vessels. What caused this coronary artery to clog? It could be a secondary effect of atherosclerosis. Okay, of course, it could happen due to age, due to family changes on genetics. It could be related to injuries or infections. It could be affected by multiple level, like if there is a change in the metabolic state, hypertension, the diet, all the component. But I was just want to focus on the atherosclerosis in the next couple of slides, because the atherosclerotic clog, once it's like released into the blood, it could go to the brain and cause a stroke. It go to the heart and cause a stroke, or in other words, occlusion of the coronary arteries. And therefore, that's what we call myocardial infarction, because there is an area after that occlusion that will be deprived of oxygen and nutrient. And this is detrimental. The heart cannot survive that. And in principle, this could be after the atherosclerotic plaque is being released. So how it is formed and when it's released. So simply put, if I want to make it the simplest scenario is that there's a change in the endothelial system. There's a damage of the endothelium. And now this damaged endothelium, it could be because of many causes that we probably described most of them now. That damaged endothelial now, it will be communicated across the vessel. So what happens? Like the layer of the endothelial tissue in the vessel is laying on top of lipid bilayers of molecules, right? So there's a lot of lipids being here. And now the damage that is being taking place on those endothelial linings could be because of the lipids themselves, like such as lipid peroxidation we described before. It could be the damage itself, that cytokines affected the endothelium. But now this will need to be cleared. And clearing that will be mostly by the macrophages, monocytes, right? The immune cells will come to the site to clean it. Now, the deformation itself could cause platelets to come into the show and stuck at that area. Okay, so now you start to having multiple components of stress. Lipid peroxidation could be one of them. Platelet accumulation is another, and damage of endothelium is the third one of them, that now recruited the police, which is the macrophages that need to clean this up. But it becomes problematic when these macrophages, monocytes, start to migrate into the layer that is below that of the endothelium. And since these macrophages are grasping a lot of these lipids, that's why they become foamy, or they are becoming bigger cells. And anyways, the soap we use in our hands is lipid-based, right? And the same thing here, these macrophages, once they start to engulf those lipids, they will become foamy as well. And therefore, they will become bigger in size, inflammatory in nature, and they are deforming the vessel wall. This also causes changes from the internal side, which is the stroma. Now we will have more probably fibroblasts come to the show. You will have some sort of fibrosis that takes place to contain this process. So you have fibroblasts come in, you have the collagen and the fibrous tissue being generated, and all that is starting to deform the blood vessel more and more. So you started with having this endothelial dysfunction that caused the streak, like the fatty streak, or just the recruitment of those cells together. But now the lumen is smaller. The more the reaction is taking place, the more that this is getting bigger, and the more as the lumen of that vessel is becoming smaller, which could be possibly now occlude the blood flow. So starting from an injury to a fatty streak to a fibrotic plaque, we are starting to have issues in the lumen nature of that vessel, which becomes at certain point occluded. Okay, and this will cause the blood to get into the layer as well, and then the clot to be formed. When the clot is formed, then the next step it would be that it will be growing, and then at certain point these plugs are gonna get released. And when those are released, that's the last step here. When the plaque is not stable and rupture from that vessel, then it will lose the adhesion and it will be flying with the blood vessel, which could partially or completely cause the block of certain arteries. And the most important that we care for is the myocardium in the heart and in the brain, and sometimes in the lips. So this causes the ischemia and therefore the death of the area that is described in this one here. Okay, I think we'll stop with this one. I'll give you 10 minutes break. Prepare yourself. And then we come back to the exam. Please get ready to have your Zoom cameras on. The quiz is already there. I hope you can have access. If not, let me know. And I gonna stop the recording. Stop recording. Yeah.